you stick it in the tray?
Yep.
Can you go let people learn?
No.
Phone calls. I totally forgot. Yeah. I'm gonna grab water. Let me know when you're ready to share, and I can air it to myself.
Yes. It's called addendum, right? Good morning. Morning. How are you? Good. Good. Life's good. Yes. They took the carpet out. Yeah, I like it. It got flooded, and that's why it's on, so we can have. I think so. Yeah, there was some kind of somebody taking care of things. Yeah. A lot of people didn't do well in this room. You know, because of the obviously sense. Some reason they put like May 21st, 2000, which hasn't even. So I called them, they're making the new over the same. So sorry. And I'll bring it. Divine intervention. I'll bring it next. Okay. I have one for Alyssa too. What's that? Wrong date on hers too. Yeah. You know, they even asked me what's the date. Oh no, that's actually the activator. You did activator? Yeah, I did it within school. Oh, nice. And then since our teacher was also one of the activators institute teachers. Hold that on. I have the PDF.
Okay. Yeah.
It's like an addendum because I forgot for some reason I forgot. It's called section 6. Anyway, I did it within school when he gave us the actual test. So once I graduated, I just just like we did here, basically. Yeah, yeah. So, how do you like that? I'm using the Arthur still. Yeah, well, I do. Actually, I had two. My one died here recently, and I need to get another one. So, I have 2 rooms. So. But yeah, you have 2 of them. I had 2 of them for years, and then one of them. I had one of the brick wall one. Brick wall one that had the recording. I had the recording and I had the what I still have is yeah. And they're made identical. They're really good. And it's a small company, family owned, and they're just about an hour south of where you call up the company, and sometimes you actually get the. But he actually does a fixing. He does a fixing. He has designed a lot. He's kind of a man signer. He and his wife run the company and ship all of them. But yeah, he's a character. He's so good. I accidentally my stand. My office stand. And the next day, it was dead. It was I want you to look at this little thing and say, is that on or off? And it's on. Well, we're going to turn that on. Works fine. So it saved me like hundreds of dollars. But yeah, I felt like such a we just love when that happens. Yeah, yeah. But there's a little switch there, and when you're cleaning it, you can accidentally. We've been using it. How do you get into that? So from my unit, I'm doing the next one, and then and then you know, they're doing minimal activation. There's more things. Makes sense. That's also I'm getting exercise. Yeah. But some people there's someone for shoulder. Oh, okay.
If you can decipher your handwriting, my handwriting, mine's no better. So good. I got it. It's okay. Yeah. Is this all the sessions?
It's really good stuff. I do it pretty much the way I learned it from you.
Are you just doing
I do it more blind. Just because that's what I don't have the I'll do the file. I'll do the file stuff. I know it is. For some reason, I do it like 4 times. Oh, right. 3 times blind. So the patient's blind, I'm blind. That way, if it comes up, it better come up 3 times. So that's 3 kids or 3 times? No, I have 3 kids. Duplicates. And all 3 have massive claim. It comes up a bit. Still one more session.
after this? Yes.
Would you find that I'm working with?
That's when we take our friends, as far as I know, but anyone. I know. That is totally his realm. Things. If you want to join, we'd love to have you. Oh, okay. I believe it's June 6th and 7th.
Yeah, I see.
So, just let me know.
Maybe I've met him. I remember faces sometimes.
So we found that kids are not necessarily playing the same violence. But that's bigger than the build up there. Part of the supplement.
They exist. Yeah. The ones I use the most are the food. Peat toxins and almost. Those seem to be, like if I have two zines, you know, they better both test. Don't, then I'll kind of like. And then I also do kind of a measurement thing to see how strong the reaction is.
If it's hard, I need to know.
And I try to find it. If they need hydraulic process, they do. I try to see what the fat will be. And when they do, it's really challenging. Set aside the paper.
Try to build richly.
2 weeks, yeah. So then we seem finite. So, well, we're thin, but we may have to start. What's that? Yeah. Well, they're gonna try, this is midterms, I guess, right? This is Dr. Clark. He's a DC also. You guys remember Chuck?
Shy. Okay.
He was in our course 3 years ago. 3 years ago. Yeah. Hard to believe. Melissa. Oh, Melissa. Hello, you're here. We think there's still a couple of you. Yeah, I think we got everybody through the practical yesterday, except for you and that wants to take it. There's like 14 took it yesterday. That's great.
Did everyone pass?
They did.
Congratulations, everyone.
Yeah, they did.
Yeah, I don't know what happened yesterday. I thought about it. I was wondering if it was a cervical adjustment, but I haven't had one in so long. Because, like, dizziness is not a symptom of mine.
So I did not tell him about what happened.
Oh,
Yeah.
Yesterday, I was, like, just woozy and lightheaded all day long, and I, like, laid down, like, the ceiling was shifting. Like, I was like, I'm not gonna come in.
Wow.
And that never happened to me. And it was all day long. It didn't resolve. I had to go. I woke up, and when I went to bed, I was like, I hope I wake up fine.
What did we do on Friday?
Cervical, but both directions. We did my whole body, but I haven't had a cervical done in a long time. So I was wondering if that's.
Might have been too much.
I feel like that commonly happens. If I get like a full body adjustment like that, I'm basically like that. I'm like incapacitated. I have to like go to bed. Yeah, I have to go lay down.
Are you okay today?
Today, yeah. Today I'm good.
So that's probably the adrenal.
Yeah, it is.
It's like
Yeah.
I check something on you.
Yeah.
I'm not gonna
And I
trust
remember
you.
sure, whatever you want. Because I remember the adrenals were, we wanted to do the DH.
So I'm just gonna do it. It's not bad. So let's try some here. Just gonna stretch this. It's not bad. She doesn't. She's not having ligament stretch.
Yeah.
Maybe you would, or maybe you would cover it usually.
Awesome. So
So some positives came out, right?
yeah. And it was, it was a good forced day in bed where I just,
Which you probably wouldn't have done, I assume.
I would have been here.
Yeah. I think we need that sometimes. You're trying to see if you know about luminosity, like when you're overworking.
So, this, did you guys get, this is an addendum to yesterday. Did you get it? So you just get it. But I'm gonna go back to the,
You get it here, yeah.
we'll go ahead and do this.
But that's what I was thinking.
I didn't want to do these yet, but,
Oh, I can go back to the other one.
yeah, go ahead, yeah. Let's keep that one kind of on the.
Right, your nose is also the same.
Change the order that I did these, and still not happy with the order that they're in. I wanted to review this, yeah, basically, we don't have enough people here to do it. So let's start, I guess, where are we?
I can go grab Dean.
Yeah. So I won't spend a ton of time on this, but it's really worth looking at. I had to do 2 papers for my diploma many years ago.
You guys are writing them, like, your own
Yeah.
research?
Yeah, and one of them I did on holographic subluxation for bent bones. And I had a guy who was training for a marathon. He had a 5th metatarsal. They kept was about to knock him out of his training. And I did a bunch of other stuff too. But I ended up. He had a kind of an old chronic ankle issue. But his 5th metatarsal tested for holographic subluxation. And I honestly didn't expect it to be as effective as it was, but I did the adjustment on it, and his pain just stopped. He ended up finishing his training and did the marathon and a whole bit. So that was so I wrote that up as one of my case studies. Honestly, I don't use it that much. I find I use it mostly in like small bones in the feet, and a lot of times fibulas, and of course TMJ. It's really can be really helpful with jaw issues. And Nicole's not here yet, right? Back there. But she, I think she may have this, so we will back to this later. Anyway, it's called a hologramic subluxation or intraosseous subluxation. So the idea is that the bone has sort of contorted and maladapted because of abnormal pressures, because of piezoelectric effect causing the periosteal, or you're stimulating the periosteum to stimulate the osteoblasts. You end up getting bone will literally bend. So, way to find it, you don't just go looking for it randomly, but where there's been surgeries or there's been a lot of times with people with arthritic knees and hips, they'll walk around with those for a long period of time. Pretty soon you'll see like bowing, you'll see a real sort of asymmetrical configuration of their legs. A lot of times those people will respond to this technique. So you have to use a 2-handed TL, and like the typical place that we use this technique would be like on the jaw. So you'd have the patient do a 2-handed TL on the bone like this, just spanning the length of the bone. And if there is an intraosseous subluxation in between those 2 points, you'll get a positive TL with a strong indicator muscle. And then you do the same thing that we did with same thing we did with the teeth. Challenge each direction, and then you do it, it's like a two-handed challenge. And then test for weakening the strong indicator muscle, and then test for what phase of respiration begins. So that's how you correct it, just like we did teeth yesterday. So there'll be, a lot of times you'll have a chronic subluxation, and it'll TL, and then you'll correct the subluxation, and it won't TL then, but if you double TL, keeps coming back if you double TL, like spinous and TP, spinous and TP on each side, then a lot of times you'll find the intraosseous, and it might be the added piece of the puzzle to help resolve that chronic subluxation pattern. So anyway, I would like to, we'll kind of wait. I'd like to check this on hold, but might be able to find one in here. This is how you do it on the jaw. Could somebody, Dean, haven't you had head trauma? You've been dropped on your head.
Why too many?
Let's check, because you might be a candidate for this.
Teeth are solid.
What's that?
Jaw, I tried to protect.
That's good. Good. Let's just check. So I'm going to need, actually, why don't you lay on your back? I'm going to need a more remote. I'll use a rectus. Hold there, right there. Push. It's a little mushy. Hold there. Okay. So I want you first to just put one hand on each side of your jaw. And then I want you to go to this side and go two-handed there. We didn't check to see that. Yeah. Now from here, kind of spanning the angle. Now, could he be therapy localizing lymph nodes and the masseter? It could be. Let's go to the other side. And then come up to there. So over here, right there, we get a positive. Yeah. So take a deep breath in. We'll just see if a phase and it does. So then it's my job then. Need a strong indicator muscle. We'll use that one. So I'm going to go in here and I'm going to just bend bone that way. And I'm going to, this is not comfortable, but I'm going to, that way. There it is. So, again, breathe in. That negates it. So that'd be my correction. So I'll go in, and it's kind of hard to get behind it because I'm wanting to do this. But I get as much of it as I can. And I want you to breathe in. And give me one more. You can feel the spring in the jaw. I'll challenge it again. That doesn't show, but then I'll have you go ahead and double-handed TL it again. So that's basically it. So you have to see. And what you would do if you found that on a patient and you fixed it, and then you did all your other stuff, then just the next time you see them, you check it again to see if it comes back. And a lot of times it doesn't. that was a pretty straightforward example of hologramic subluxation. You might find one in a metacarpal metatarsals. They're real common. You find them anywhere. Collarbones, real common. Especially collarbones that have been broken and then healed. And so, of course, you would also find IRT a lot of times where you would find this too. So, anyway, shows all the different ways you can pry apart. We didn't TL here on Dean, but if we would have TL'd over the mentai area or the mental area, we would have pried apart, pushed together, did shear motion, so we found something that that reproduced the muscle change, and that's how we would correct it. Orthodontia, a lot of times if people have had a lot of orthodontia or oral surgery, they might need something along with TMJ. So cranial, there's a couple of cranial that I wanted to run through. We try to workshop them. We talked about the different categories of cranium, the rotational faults, there's sutural faults, and there's flexion extension faults. That's three main categories of cranial faults. These would be considered a rotational fault. You've got a sort of a rotation of the sphenoid and the frontal bone, sort of this being the front, this being back, sort of this way. The internal and external frontals, one of the things that would lead you to think they might have this is you'll see an uneven size in their orbit and their nostrils. So, for example, on this image, the internal frontal would be most likely on the side of the larger nares. The nares is larger, and the eye socket is bigger on the opposite side. The external frontal is just the opposite. Often there'll be a scalene weakness associated with this, but you can also have scalene weakness associated with a zygomatic sutural fault. Something you might want to remember. Tenderness over the eye, the supraorbital notch, or I think in the original write-up in the synopsis, they would monitor the pain at the eye. I don't do that. I don't recommend it, but you'll get tenderness here that you can monitor. Honestly, I don't find that to be as reliable as just using the TL, doing the correction, and then re-TL it. Third localization is going to be two-handed TL. And the challenge is going to be on the maxilla from lateral to medial. Through the zygomatic. So the correction is there's three parts. You press on the hard palate until the eye pressure or the eye pain is reduced. Now that's kind of hard to monitor. But that's the way it falls. It's basically like a sphenobaselar correction, only your pressure is a little more anterior and a little more medial to lateral. Remember, with the sphenobaselar, your pressure is pretty much straight up through the vulva. Second, then as you go to the high sphenoid side, and you press the try to pull down the pterygoid process. Now, this is very difficult to do. You got to get up behind the molars and best you can kind of pull down. I usually just get on the molars. I get on the back molars if they're there, and kind of use that as my handle. You get on the pterygoid process, you can break it. I haven't done that, but I know some people do. And then it gives people a real sore throat for fun. And then you go back to so you go part palate on the side of the internal frontal. You go, you pull down on the pterygoid on the other side, and then push up on the pterygoid back on the other side. So that's the three-part correction. External frontal, it's pretty much the opposite. The external is going to be on the side of the larger eye. So you're going to see a tenderness sort of cross the arch this way. And the therapy localization, they say, is on the pterygoid process. Honestly, I would go by eye tenderness or the other thing you can do is pull the tooth out. I forgot about that. I would go by this, actually. As long as they don't have dentures. You pull down on a front incisor and you test for weakening. That's for the external. It's a two-part correction. You go opposite, the same spot you would for the internal frontal. You go opposite the side of the external, and then you push up on the pterygoid process on the other side. Not going to do those on anyone unless they really want me to. Okay, so one I really do like. This is one cranial I really do like. It's the nasosphenoidal, and it's associated with also the pituitary drive technique. So it's often found with endocrine imbalances of various kinds. Dr. Wally used to associate this with specific gravity of the urine. So the way to challenge it is basically the nasosphenoidal area aimed towards the temporal fossa on the other side. Challenge, dynamic challenge, down challenge. You test for strong muscle. You do the correction the same way on the phase of respiration that negated the challenge. And then you go to the mastoid, and you do about 10 pumps on the mastoid.
So you did a rebound challenge?
Rebound dynamic versus static. So this I really like. A lot of times I'll do a spheno-basilar and it just doesn't feel like we got it, and then so I'll go back in and check for these, and I think it really helps get more movement in that sphenoid. So another one is the universal fall, and this one's kind of tricky. There'll be tenderness over the occiput, but that could happen with a number of things. The TL is going to be a two-handed TL like that. The same TL you would use if you were testing bilateral, so for bilateral muscle weakness / occipital fixation. So you basically challenge the mastoid, one up, one down, and each side, and then you look for the phase of respiration that negated the challenge. Then you correct it opposite the challenge. So, often there's a sacral, often a sacral sort of wobble type fixation that goes along with the universal fall. That leads us to diaphragm. But there's one more thing I want to say about this. TL, tenderness. Yes, okay, so this is something I want you to know. Remember for maybe future test questions. So the muscle will strengthen from a breath in, but only in through one nostril. So it could be related to ionization, which we talked about yesterday, but it will strengthen in one nostril or the other, but not both. So that is how we determine that we check for universal fault. So then you do the TL challenge, correct? Correct, and accordingly. So. Concerned about not getting some of this, but I wanted to go over TMJ again and maybe the risk, although, but I was hoping to do it next week. We'll do it later. We'll review those later. So we're going to look at diaphragm, and then we're going to look at hiatal hernia, which ties right in there. And I don't really like the term hiatal hernia. I have a patient who just got diagnosed with legitimate sliding hiatal hernia, and she's looking at surgery. That's a true hiatal hernia. It's herniated through the hiatus. The term gets used a lot for what would be more accurately described as esophageal jamming or congestion, or you've got the stomach's kind of sucked up against the diaphragm and it's interfering with the cardiac sphincter. That's a thing, but it's not herniation. It's not but a lot of times those are called hiatal hernia. And so, and you can reduce a true hiatal hernia to some degree. Often won't stay, but you use the same technique to pull a stomach away from the diaphragm, where it's kind of sucked up and starting to interfere with its own muscular action. That's a visceral correction. And then you can also use that same technique to pull, if they truly have a hiatal hernia, you can pull the stomach down out and pull it out of the slot. But the problem is the opening has widened and it doesn't have the integrity to stop the stomach from moving. That's often the case with a true sliding hiatal hernia. So I've got more on that later, but diaphragm is so the attachment points to the diaphragm are so extensive. We've got nerve supply from the thoracics. We've got nerve supply from the neck. There's this interdigitation of the psoas muscles with the back part of the diaphragm. It attaches to the ribs and the lumbars. So, and it's, say the heart's the most important muscle in the body, but honestly, the diaphragm is right up there with the heart. So, of course, basics, the diaphragm contracts, it flattens, it creates a vacuum, which helps suck air into the lung. But then it also creates a positive pressure to the lower abdomen, which is what aids in lymph movement and circulation, propelling. So it's basically this pump up and down that it's pumping the chi, it's pumping the blood, the lymph, and pumping oxygen and carbon dioxide in and out. We all who are in practice have patients with asthma. It's pretty common. We see a lot of people with breathing problems, through mild forms of asthma. These people could really be helped a lot. kind of adjusting and teaching them how to exercise differently. But things like vital capacity, these are all, helpful measuring tools. Breath holding time, average person should be able to hold their breath for ideally 40 seconds. Probably most of you guys can. But, yeah. I'm not sure, I haven't tried lately, but I mean, that's would be considered kind of the average normal. Also, one thing we'll look at when we workshop this is we'll look at rib expansion. And you can actually put a tape measure, go from exhale to inhale and look for a measurable rib expansion. Spirometer, there's different things that respiratory therapists use. So you're looking for chest expansion, and I usually just put my hands on, but you can measure it. It's kind of fun. Anyway, this is kind of some of Tim Francis's stuff. He said thiamine deficiency. I think supposedly Tim's things. You won't see that on the test. So the TL is going to be just under the xiphoid. What else is there? But what is that? I don't have a picture. It's just under the xiphoid. And I have a picture of that. Anyways, right where where the heart long point is. So you might think in two planes if you do get a positive at that point. Better check maybe heart rate too. The psoas muscle is interdigitated, like we're saying, with the diaphragm. So it's very important to test the psoas against inspiration, expiration, and also use the TL to the diaphragm Chapman reflex to double check to see if it's the diaphragm that's connected to the psoas. This point here, that's the bregma, which is, of course, the Bennett point for the heart, brain, and lung-related muscles, the diaphragm. So, and you've got also these other two neurovasculars you can check. But this one is really, a lot of times if you have like a jammed sagittal suture, you can have that point being treated. So you can't really correct hypertonic psoas by spindle self-correction, but you can use the sedation point, which is on the sole of the point. I mean, I've never been able to be convinced that you can get at the psoas well enough to spindle down without really pushing through a lot of organs and muscles. But anyway, QL often, so the QL and the psoas are often in reactive muscle relationship with the diaphragm. So, any kind of problem with breathing, if they have a positive TL xiphoid, you look at all of these things. So C3, 4, 5, keep the diaphragm alive. So you look at the cervicals, you look at the Lovett of C3 is L3. And if you remember, C3, L3 also is the Lovett pair for what?
Open ICV? Or is it closed?
Closed ICV.
I knew it was one of those.
Closed ICV, right. So what's for open ICV?
C5L1.
Right, C5L1. C5L1 for open, C3L3 for closed. Excellent. I should have asked more questions about that yesterday. I was tempted to ask you more about ICD and that too, but take it to the next step. Kind of did a
We're
little bit.
going to.
Some of you that were in my class last year. Okay, so let's see what else I can do. Okay, these are still handy for you. So back up from that. So someone come up here, please, with a couple of psoriasis and diaphragm. Anyone? What's that?
Thanks, Steve.
I usually don't have too much wrong with you, though. So one of the things you always want to do, and this is whether you're looking at the pelvis or anything else, is to look at toe turn in. And if you've got less toe turn in on one side, that is going to be a hypertonic psoas and or a hypertonic piriformis. So right away, you know you got something asymmetrical in the pelvis, but she's really good that way. So we're going to test the psoas. Hold there. And that's intact. That's intact. Let's sit up for a second. So I'm going to put my hands on your ribs, and I'm going to have you breathe in. Nobody has a tape measure, do they? Taylor's tape measure on? Really? I was kind of kidding. I didn't think anyone would actually have one.
For clinic.
So she's pretty even. She's not really, let me just check here. Might not be. Now touch right under your xiphoid. Yes. What's that?
Hurts.
It hurts.
Yeah.
Okay. Now just touch lightly. Just contact it. So that's a positive TL. So go ahead and take your hand like this and just put it right on your sternum, kind of spread it out that way. This would be the Chapman. That should TL too, and it does. Okay, laying back. So good. Yeah. Now, she's strong. Hold there. I like the psoas because it's relationship to the diaphragm. Go ahead and touch your sternum like you did just Chapman. And that, of course, weakens you. That's going to weaken everything. So if I had my percussor, I would do a percussion. Right? But I don't. So I'm going to have you ease up. And before we do that, let's see. I want you to touch the top of the head, the bracelet. Okay. So bring this up. So we're going to treat both the neurovascular. There's 3 points, so I'm going to get behind your head. So I'm on the 3 Bennett points that we showed. Hold those with a little bit of tug. A little bit of pulse. Feeling for pulse that's kind of equal. Down. Touch that top point again. So that doesn't show. And now go back to the Chapman. We still need to. That's there. I need to treat that. So I'm just going to have you with both hands. We're going to use your hand's going to be the percussor. You're just going to get right on there and just kind of. So, okay. Go ahead and breathe. Good. Come up a little. You'd also want to check the pec minor and probably check for retrograde if you see issues with the diaphragm. Now, I haven't checked her for any subluxations. I want you to touch right here. And breathe out. And down and touch right. Breathe in. And breathe out. Basically, I just treated the Chapman and the bed points. So breathe in. I might be imagining it, but it feels like you're breathing a little deep. I wish we would have gotten your tape. Anyway, thank you. Does anyone in here have breathing issues?
The hiccups all the time.
Um, I'm gonna, does anybody in here know they have a type psoas? Some of you always have like, so I want to see if this relates to background. And then we'll move on to the stomach. Oh, I thought somebody said something.
No, it was just now.
It was what?
It was a chair.
Oh, okay. I thought somebody said, huh?
No, that was the chair.
It sounded like that. Ooh. Okay. Ooh. What's going on? Okay, so take a deep breath, and that's both. Okay. Breathe out and breathe in. Okay, so both psoas muscles are weak but strengthened with in-breath. Touch your oxygen. Breathe in. Breathe out. So breathe in and breathe out. So she has a respect. Lay face down. We have to fix that first. Sorry. Let me get you paper. Didn't we do something on this yesterday? Friday? So I might have gotten in over my head here. Go ahead and breathe in and breathe out and then breathe in again and hold. Okay, so I'm just going to do a basic sacral inspiration. So breathe in. And it just moved a little bit. Breathe in again. Good. Give me two more just like that. Deep breath. Remember, the sacral inspiration is a direct correction. It isn't a rebound like the others, most of the others. One more time, breathe in. Now hold there, push, push. Good. Breathe out. And hold. Yeah, so that's what she needed. Now lay on your back. A side trip there. Those are pretty even. Those are pretty even. Actually, no, those are. Did it? Actually, you're pretty good. That's what I'm looking for. But since you're here, there, breathe out. I want to make sure that cranial sacral thing isn't still. I want you to touch right here. And then I want you to touch, I'm having her touch the Chapman reflex for the stomach. Now, I want you to just pull up this way. That's how we challenge for esophageal jamming or hiatal hernia. Now, the patient can do it. Usually I will do it. I'll just do a static challenge up another week. You can also pull, sometimes they might have a weak PMC and you pull down and strengthen it. But pushing up is a real clear indication that you've got something is crowding there. It's not happy. So that's the main way we test for hypertension or esophageal jamming. So the weird thing is if you challenge it, if you go to the trouble of challenging it, you'll find this challenge positive more often than you might think. Even people who aren't having digestive symptoms. It's really, really common because I think most of us eat too much. We eat too much and we sit too much and we do all kinds of things that really stress that area. Yeah. So maybe we should check it after you've had a chance to digest. Someone else come up here with a stomach that would allow me to test them. Of course, you you'd have history. You'd have history that there's digestive issues, bloating, gas, indigestion, GERD, that kind of thing. At first, I'm going to use, I think I have a slide with this. I'm going to use what's called the Rittler's point, which is right on the edge of the rib cage on the left. And then the Chapman reflex, which doesn't show, Rittler's point does, and I'm going to have you press up. Now we're crowding her hiatus, and of course that shows. Did you just see? Okay, no, stay. Let that relax. What's that? Oh, I'm so sorry. That's right. Oh gosh, yeah. Can I test above the wrist? Sure. Is that okay? Do a modified. Okay, good. So go back to this. So that does show. So the Chapman is positive, Rittler's point is positive, and the superior visceral challenge is positive. That is enough to indicate you need to do the visceral manipulation. And basically, how we do that is okay if we do it. You have I prefer if people haven't eaten, obviously. I'll ask them, did you just eat? Yeah, it's been hours, so I'm not too worried about that. But, so the way we correct it is you bring their knees up so their abdomen is slackened. You find the edge of that rib cage. You're just a little left of midline. You use your hands like so, and you kind of ride off that rib cage as you breathe. As she breathes, that kind of brings the stomach down towards my hands. Breathe in again. And then let it go. So I'm taking my time because my fingers can kind of sense at some point where the top of the stomach is. Breathe in again. And there you go. And it's hard to get clear to the top of it. And then the correction, there we go. Breathe in again. The correction is like that. In breath, then and you try to get a capture of the stomach. As they exhale, you're trying to hold that stomach away from the diaphragm. So you're letting their diaphragm and their breathing mechanism do a lot. Diaphragm flattens, brings that stomach more accessible, and then as the diaphragm comes up, you're trying to hold it. So you're not really pulling it down as much as you're trying to hold it back while the diaphragm lifts back away from it. Usually you do it 2 or 3 or 4 times. When you get like that last one, it'll kind of go, there'll be a little suction shifty kind of thing. That will tell you that you probably got it. And I like to think of it as the stomach kind of suctioning away from the diaphragm. It should have some space there. Okay. Yeah. So we go back and just retest. Push, push. Touch Riddler's. Nothing. Touch the Chapman. Nothing. Challenge the tummy up. And nothing. So, the indicators will clear. Got it. Please rise. Oh, I'm sorry. You need to put caution tape around. So, the bigger picture is you have visceral dysfunction, i.e. hiatal hernia, hiatal jamming, esophageal jamming. You also may very well have some major muscle, one of which could be, oh, I'm sorry. Looking down and up. No, you don't. I'm sorry. Yeah, you're not correcting on the phase of respiration that negated the challenge. Yeah, you're using it as a way to get better access to the stomach. So that determines the phase of respiration. Sorry, I didn't make that one clear. It seems like, because we're always talking about phase of respiration. Yeah, and if I've got people who have had patients who've had these stomach surgeries so they could lose weight, and those surgeries are pretty brutal, and they will have problems ongoing. And a lot of times the problem is this kind of thing: the esophagus is kind of jammed up, their stomach has been altered. There's usually adhesions around there, so very gentle. I do these adjustments. A lot of folks that have had. I've probably got a dozen patients. Also, you want to be careful with, sometimes you strain that tissue, and your tissue integrity isn't as good. But the other things to look at, of course, are the neurological components that furnish the diaphragm with all of this information. And that's going to be pretty extensive. So cervicals, upper thoracics, upper lumbars.
The lower esophagus.
Oh, I won't say that I have, but I think I know what you're talking about. I haven't done that on somebody who was diagnosed, but I've done it on people who had pretty tight tummies. So, some people, it can be really game changing. I've got some patients, they come in when they know it's time to have their stomach manipulated again, and because it always seems to work. So I kind of let them determine. They kind of know when they need it, and they're usually right. Same with the people who I've done intranasals on, these station tubes. That's a pretty unpopular technique, but people will come in and ask for it when they know it's anyway, I would like to. So basically, if you have a hiatal issue, you have a stomach issue. You've probably got a psoas and diaphragm. So You want to look at, certainly the psoas, the thoracolumbar, and the upper thoracic. Basically, it all comes back to the spine. Let's workshop this. We have enough people here now. Oh, do you guys want to, do you have any questions about TMJ? Seemed like a lot of kind of all over the place stuff. So there's a couple of things I want you to kind of remember when you go back to look at it. We will have time to check TMJ, but the first thing you do is you check them with bite, no TL. Strong indicator muscle, have them bite down. Nothing happens. That's a good thing. If they bite down and they go a week, check for neurological. I would, because you're going to be having them bite down later in the protocol. So they bite down. Let's say they bite down, nothing happens. Good. Okay. Then you have them open, and if the strong indicator muscle goes weak, that's an indication you've got hypertonic muscles in the closing muscles. So you're stretching the masseter, temporalis, internal pterygoid. Those muscles are unhappy. One or more of them is unhappy. So you get a weak muscle. So then you go to TL, and you TL the masseters. You TL the internal pterygoids while the patient's opening. TL the temporalis. One of those will negate the weak muscle. TL will be positive. Say it's the masseter on the left, and then you can even isolate down to the middle division. That part of the muscle needs fascial flush. It needs iron down. Just like a hypertonic muscle, just like a hypertonic hamstring. That's phase one. That's the first treatment step. Now, once you cleared the fascial flush muscles that were brought to light by the opening, then you go to TL to the TMJ itself. So you have the patient TMJ or TL the joint itself, and then you have the bite down. Now they didn't weaken before without TL biting down, but now they weaken. That tells you that there's a need for spindle down of one of the closing muscles: masseters, internal pterygoid, temporalis. So then you go back through. So then you actually TL each individual muscle while they bite down, and then you'll find the one that needs to spindle. It's the second phase. Now, if they with TL weaken on opening, that's an external pterygoid issue. I'm sorry, external pterygoid issue. That's the one where they're way up in there, and you have to get on there with your pinky finger and stretch it. So the first step is no TL, biting, opening. If you weaken on opening, then you use TL to find which muscle needs fascial flush. Next step, TL the TMJ, bite down, open big. If you weaken on biting down, you need spindle. You need to spindle down one or more of the closing muscles: masseters, temporalis, and internal. Then with TL to the TMJ, you open and weaken. That's an external pterygoid issue. Now you take one hand away, move back and forth, and you can determine which external pterygoid needs treated. You can also tell which external pterygoid needs treated by jaw deviation. If the patient opens their jaw and it goes to the left, it's the right external pterygoid. It's overfiring. That's the one that needs to be done. That's TMJ in a nutshell. Does that make sense? So your treatment tools are fascial flush and spindle down. Okay, so those are the two tools. And both techniques aim to reduce hypertonicity. So, you can also spindle up. Sometimes I will spindle up temporalis divisions in addition to spindling down on the other side. So, shall we do any questions on the wrist, carpal tunnel, elbow? How would you adjust a radius if you determined the radius was interfering with wrist extension? Or if the radius was interfering with supination? How would you adjust it? How would you determine how you would adjust it? Yeah, static challenge. Yeah. So first you would TL the joint and it turns on. Then you would challenge the joint, P to A, lateral B, wherever wherever you think it might need to go, and test it. And then that's how you would correct it. You can, yeah. I think it's helpful to use respiratory with a direct challenge. You're not testing what the data challenge necessarily, but I just think it's helpful. As long as you keep the chi moving. With the rebound challenge done first, I definitely want to use it. So say you had your radial head was sort of lateral posterior. That's how it's statically challenged. Would you press it the other way? If it's static challenge and you get a weakness of the strong indicator muscle, you're going to go the opposite way. Then you retest the muscle and turn it on. You got it. How would you adjust a lunate in the wrist or a navicular scapulae, aka scapulae? Challenge, you could use a strong indicator muscle somewhere else in the body, and you could do static challenges. Sometimes, yeah. I really like just getting on them and moving them, but sometimes the activators, especially on kids, little kids, old people. Some people are just freaked about any kind of bone popping. I'm part of my practice that are folks that they don't want any popping, none of that popping stuff. So I use respiratory, I use all kinds of other stuff. I used to find those patients kind of a pain in the rear, but I actually really like them now. They forced me to really embrace gentler techniques, and it's helped me prove that the gentler techniques really especially with people who, people who have ligament stretch syndrome. There's a lot of folks who can't tolerate really big wrists, and it may or may not be emotional thing. They could have been traumatized in some various ways. That all kind of things. Some people absolutely hate that adjustment where I kind of roll them up and kind of smother them. And most of my patients love that adjustment. I've got people that they hate it. They'll ask me not to do it. It freaks them out. It makes them feel claustrophobic. And so you have to really listen to your patients. They'll tell you. They trust you and they get comfortable with you. They'll tell you exactly how they think, how they feel. That really helps. Sometimes it's not what you want to hear, but so anyway, diaphragm, psoas, breathing issues, all of this stuff is what you want to look at. You're really dealing with the most elaborate, complicated part of the torso. Neurologically, biomechanically, there's all kinds of things going on. You've got all these big forces acting various ways on the spine, on the psoas, then the diaphragm's trying to stay anchored and breathe during it. So here's a kind of a graphic of a sliding hiatal hernia. Sometimes they can get clear up into the chest cavity. Generally short. You mentioned yeah. Now, if you look up anything on hiatal hernia in any of the medical journals, they're always talking about real diagnosis, evidence-based on imaging and hernia. They won't acknowledge the kind of like functional issue, visceral issue that we're really going to be exposed to. Anyway, it really comes down to the integrity of the holes, of the boundaries of the holes. And anything that makes this muscular system imbalanced and cause it to lose some of its integrity. There's the SOAD right there. So belching, a lot of times people have angina and they go to the ER and they unfortunately don't have heart issues. They have a hiatal hernia, or they have chronic indigestion. You remember, well, a couple of us might remember, there was a drug called Tagamet for many years, which was a prescription antacid. It was an anti-heartburn medication. Now you can get it over the counter, you get it at Costco. And Tagamet was one of the go-to, before they came out with the H2 blockers and some of the much more heavy-hitting heartburn medications, Prilosec and all those things. Tagamet was one of the leading heartburn medications. Tagamet is not an antacid. Tagamet is an antihistamine. And I didn't know that until some years later. Dr. Wally, he would actually test people on Tagamet. He thought they were having an inflammatory reaction. He would use it as a test. So a lot of heartburn is caused by the stomach reacting to foods that the patient is intolerant. And so there's all this histamine release, and a lot of the histamine release down in the upper part of the small intestine. And that really causes burning and all kinds of discomfort. So in mainstream medicine, heartburn is just lack of antacids in your diet, or it's just lack of H2 blockers. But these people are eating something every day that is making them sick. And it could be gluten, it could be something weirder, but it's something. And it's the way they're eating, the amount they're eating. So many people come in and they want another kind of supplement, or they think, oh, I need to get on this supplement, blah, 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 but it's their diet. Their diet is just back. And you can't fix them. They'll fix their diet unless you can help them fix their diet. Always, a lot of them do. Some people don't have any. I have a lot of people who are really hip to new thinking, and they take a lot of vitamins and they read a lot of stuff. And then I have some people that not so much, and they'd be likely to take Tums. It's like, and then if the Tums aren't working, they go to the doctor, and the doctor says, well, you need this H2 blocker. They'll take that and see they won't even question it. And then pretty soon they're still having heartburn. But one of the things that kind of cracks me up when I take a history, and I'll ask the patient, well, how's your digestion? Do you have any problems with digestion? They'll say, no. And then you go on, and well, they're on Prilosec, they're on this, they're on that. Yeah, and well, since I went on the Prilosec, I haven't had any problems with my digestion. So they actually think that their digestion is good now. It's not, it's terrible. But the drugs are sort of keeping them from experiencing the real symptoms. And that's hard because you know, if they go off the drug, then symptoms will come back for a while. It's hard to get them off and convince them to change their diet. The symptoms will go away. Most people just don't have the capacity to take on something like that. A lot do, but don't be surprised. We, in our sort of church, we think everybody wants to be as healthy as possible, and everybody wants to have control over it, but it's just not true. It's just not. It's not a priority for a lot of people, unless it becomes a problem. So, when you, don't forget emotions. Remember the bladder, stomach, and gallbladder points right here. So what's gallbladder? If you were going to just take a wild guess, what emotion do you think would be dominant emotion if you had somebody had a gallbladder that was related to emotion? Just throwing that out.
Anger.
Bitterness. Yeah, anger, resentment. In NET, they say resentment is gallbladder and anger is the liver. So, what about stomach? Stubbornness.
Anxiety.
What's that? Anxiety, stubbornness. There's something to do with ego. Kidney, fear. Anyway, I think what I would like to do is everyone challenge each other's stomachs. This is a really important technique, and you use it all the time if you want to. To look for these, you'll find them all the time, and it can really help people. Now, if their diet is terrible, and you're working with them and they're making little changes, and you can really help relieve a lot of what their body's reacting or how their body's reacting to the diet by adjusting their stomach, adjusting their neck, thoracics, making sure their ICV is working, because the ICV in the stomach, there's a lot of communication there. You have those main sphincters, the cardiac sphincter, pyloric sphincter, sphincter of OD, the gallbladder. Then you've got the ileocecal valve sphincter, and then of course the haustral sphincter, kind of sphincter, and then the anal sphincter. So you got all these control valves that all communicate with one another. So a lot of times you see ICV and stomach issues hand in hand. Riddler's point, you won't find that on, that won't be on your test. That's kind of, I don't know where I learned that years ago. Riddler's point is right here. It'll be tender as heck on people when they have hypochloremia. Your stomach isn't producing hypochloremic acid to the, enough. Remember, production of hydrochloric acid is zinc dependent. It also has a lot to do with stress level too. So the more stress we're under, the less likely we're going to carry out this very physiologically expensive production of hydrochloric acid. But the body is slightly alkaline, and then we have this one area where we have to drive the pH down to level 1.5. That's a pretty amazing thing the body does. So it's an elaborate mechanism that takes energy. So and of course, if the body's under stress, the communication with the digestive system is cut way down. Don't need to worry about digesting if your life may end soon. The way the brain looks at it. So let's test. usually fly. So you spend a lot of time.
Where were you yesterday?
Dizzy.
Dizzy?
Yeah.
Oh my gosh. Oh.
Are they flying or are they on a bus? So you just kind of live with this.
I didn't bring them.
Or pretty young, pretty young.
I have a hydro test
Of course,
tomorrow.
everybody's young.
But it's like hard.
Yeah. I knew it was hard. She's so good at understanding that.
I was
Open-ended question. What the heck is that?
high school football.
Yeah.
It's what, stage?
1960s.
Yeah.
And I trained now.
I knew she was going to be hard.
Okay, and they're playing ball. That's
But she's like, I was just ready now. Let's see how it is.
perspective.
That's how.
Oh, yeah. I mean, I'm going to be able to first test. I don't even know.
That's good.
Yeah, I have no, like, some people know that. I thought I did. I saw my grades.
I know both was in this. Then passed her final.
It's just all like, it's only one answer. There's no variation, no synonyms, and stuff. Right. So risky stuff.
Risky. And I want to work on my, because technically I reset myself in my stomach. So, yeah. Bilaterally, but my oxygen just went split, but then he did my sacrum.
Sounds like number one indication. Yeah. Go for it. I need you to be well testable.
Yeah. I can feel it moving. Or like on my sacrum. Recording me.
Oh, I'm gonna come. I was standing
That's
right.
right.
Whoops. See right back for a good 5 minutes.
Put your butt there.
Yeah. Okay. So, did we check emotions? We checked your occiput. Did we check your neurovasculars?
No.
Okay, so we'll check that.
I wouldn't be surprised if I had emotions.
I'm gonna check it my way. It's not gonna be his way, but I'm gonna check it.
I think that's good enough.
Drink the whole water.
I drink a lot of water. I do.
I tried. I had to get
I
it
dabble.
I dabble.
And then okay, let me just drink some electrolytes. Maybe we'll balance it out.
I can't say electrolytes. I have to do it.
Oh, right.
Yeah, so just
So you just get your electrolytes from food.
yeah. But I also like in general don't have sun tolerance. I have sun tolerance, and I cannot have sun. You never heard of that? Yeah, no, I don't know if it's like an extreme phototoxicity thing, but
Do you have zero dose of pigment, whatever? Zero derma?
I mean, I wear sunscreen every day, but I'm half Mexican and I actually get very dark. I don't look like this, but no, I was out in Texas and I was out in the lake all day and drinking water and stuff, but I got home. My whole body swelled up. I was so red, vomiting. I mean, like extreme dehydration. It took me 2 weeks to get over it. I had burns just full body. It was the worst. Big old bubbles.
I've
I
heard
had
of it, but
edema everywhere.
I've
Yeah.
seen people like get on like their face.
No, it was full body. It was awful. It was the worst thing. And ever since then, like being outside in the sun for months, getting overheated, I will be out. And then when I got my kidney out, it's even worse. I get hyperfire. So.
Dang, I'm sorry. That's
No, it's okay.
And then you have to be even more careful because you get dehydrated quicker if you dry heat.
Oh, my husband's so stressed all the time. He got me this big old hat at hospital. She's like, this is for when you're outside. I'm like, okay.
Nothing new, we were talking.
Yeah. Circle back.
Rein it in. Yeah.
Okay. Yeah. Okay.
So have you ever done detail?
I think I heard you
Week on.
I know.
It's different. So it's. It's the NET ones.
Nope.
No, it's Dr. Whitney. So we did all that. Oh yeah, that's what I meant. Was we.
Oh, I guess I'm not. Sorry.
Yes. TL challenged it upwards, we challenged it down.
Oh, yeah.
No. So I like to move here. No, just sent it one. I did strong.
Hello.
Okay. Just regular.
All right. That's not what I thought. Don't be biased. Be a good patient. Do it out of your brain. Now I'm gonna do it again. You and you. You screwed me up.
So, because I know I thought about it. I think I said it. Let's just do all. Okay.
There, but right there. So as really
Exactly.
It's just gonna
I didn't do yours.
so
Observation.
I think
It's top of the toe.
yeah.
It's just another. The left.
so under the
Okay. So
Just like this.
so pull down. So what I'm so that's pretty straightforward. So
Take it off.
correction.
you're emotional. Why are you emotional? I'm just kidding. I don't have my chart. I could actually probably follow yours. You follow what I did.
Yeah.
Primary, secondary. Oh, you did. Oh, you did. Okay.
I wasn't gonna ask you straight up.
Okay. I don't have. Probably do this. If you want to clear it just this way, you can try to quick see, and then I can touch your pulse points if you can't figure out what. Have your NET on there? Perfect. I don't know why I just haven't put it in that card.
I mean, you could look at motion.
I just like it because I know a lot about So because it's
Do you do that?
and I wrote like our pulse on here. I know, I was like, here.
I was like, I know what you did. Yeah. It was not. Maybe.
I don't know why, I always feel like it's like computer code.
It is like caffeine. It is like it's interesting. It's interesting to me how intentionality is bias. Obviously, we also learn on each other. We have that issue too, and I try to follow that. So that's like
Also, you see shrinking.
I just realized that. That muscle. It'll be a lot of week.
Better.
This is a whole thing. And that was.
We've got low box, sacrum,
And check that.
It might push your year. It would.
Yay.
Probably do that
Check for iliac.
and then. Yeah, let's do that after.
so there's some components.
The main thing is,
Do you go from this side?
well,
So what about my cat one?
Well, I'm seeing if it's
Maybe my.
it's either like a cat or I mean you did your sacrum then I was talking about the celebrity might take where this is the you know what I'm talking about?
I know how to do. Oh, I know how to do it. I don't know specifically.
I just don't know.
You go like. Well, this is how I learned it from not from him, from school. Like you go from the areas, and then you go like midway in between, and then you just like. Dig like my.
But I just want to consider more super time. I wonder
I'm getting the phone and allow.
trigger just like he's
Several. You're in the right place.
Apparently, I would say this one. Like but overall, it's this.
This one is a little, I like turning them, I didn't feel it, but they look rather even comparatively. Alright, so let's check yours.
It's just a heavier weight. Maybe it doesn't work black. I mean, we've got that, those tests, that's what you don't.
Yeah, that's right.
Oh, yeah. Sorry, I don't know why I made like a liar or something. It wasn't like.
No, you're good. If we don't have, I'm gonna go start.
So just feel around. Forgot what that was. Remember like the short leg? Well, just an idea.
I guess they're not as common as like
The days of the 30s.
On my father.
You want me to lower the whatever's comfortable. I don't want to disrupt your nervous system.
Oh.
Yeah, no, I agree.
Once a month is symptomatic. Yeah.
You're pretty good. But I think you just fixed it.
okay, guy. Oh, did you?
Okay, I got one so turn back on. I can one of them was emotions. And she had all on her stomach.
Lady back. So we got, I want to.
I was gonna check and see if she, in her jacket.
Okay, so,
I have her drink some water. You don't want to be
so, you try, what else?
Declared emotion. I was getting ready to check spindle and PTO, and then if that didn't work, then I was going to check the chest on her. So. But I also didn't know, I don't know how to check for a psoas release. That's what I was thinking, spindle or PTO.
That's just, that always acts.
Could it be category?
So, it could be, you didn't check the category?
Not yet.
Okay,
Oh, sorry, that we were
Yeah.
going there.
So, single-handed TL.
No one saw it. Yeah.
It's probably so it's a tattoo. So here.
My shoe, okay. Would not. We have the blocks.
Oh, we do. Make that's enough. Yeah, that's enough. So, yeah, let her sit there for just put 30 seconds.
Yeah.
That's sweet.
Are you gonna switch to the other?
Then, so that's pretty much a positive. You can find
Okay, I have one.
Yeah, a little bit better. Yeah, it
It's
is.
a little mushy, but it's
Yeah.
It's not, we're not in lunch break.
No. Oh, yeah. Honestly, I liked it, but like, yeah, I thought I was over, like, I don't mind, like,
Oh, yeah.
but like, better people than
I don't like
so it's like,
No, I don't.
Yeah, it just tells the pulses.
that's like anywhere.
Pressure test is just a little off.
A long time ago, I started drinking salt.
Okay, so
No, it's like, it's
Just a little.
no.
little blessing in the song.
Baby. Come here, I need a red.
You have.
I know, but yours are good.
Right on.
I'm not sure that's best first, is what she's asking.
Yeah.
Alright, we got it.
And they're also big. Yeah, the
That thing was huge.
I can't. I couldn't say that. I love popcorn. No, it's from. I haven't. Well, yeah.
Anyway,
And I was just. So I had to say. And I couldn't know something.
Carla had, it was not music.
Yeah, hers was.
It was like very like.
Psychosomatic. No, I think that like it was like a lot of like. I mean, there are other things. But
No,
mustard, yeah, but it was definitely really mustard. I definitely really like mine.
But you don't like when you looked at something one time.
No, yeah, I don't.
And remembered it. And I was like, I don't even know how you did that.
I have a card where I remember things. Other times, I'm like,
We didn't do it.
Okay, guys. We are gonna work on Dr. Clark here. We're gonna use his found on him today. So, is that table go up? Yep. Can we use that table? I've got to raise it up a little bit.
Yeah.
So, we're introduction. Sure.
That's Kayla. Say hi to Kayla. Hi, Kayla. Just fun.
Guys? So.
Let's see, AFib.
Hello.
I'm in normal sinus. first episode was back in school, 20-something years ago, and then the AK acupunctures reset my rhythm. And then it came back 10 years after that one. And then just in the hospital with a bag of magnesium, put it back in the rhythm. Then the last episode was about 5 years ago. And that's, I'm trying to think of the machine. Someone was testing on me and they got close to my, what is it, baroreceptors, and I about passed out on the table. It was the one where,
Is the vagal stimulation?
it was where they were trying to muscle test. Electrons Plus, maybe? What is the name of it? Anyway, you'd go through, the practitioner had they were grounded, then they were running a current through.
Oh, machine. Where they have to hold the ground and touch you while.
Yeah, so you would hit points and, oh, it's working or it wasn't, and then he went up in my neck. Anyway, I had already had AFib a couple times, and I went into the trainers. I was like, I think my heart's gonna go out of rhythm at some point. They're like, because I just feel weak or weird. Rhythm was fine, and then like 3 days later, I went out of rhythm. And then that time they did a cardio version. And then I've had weird symptoms ever since the last 5 years.
That was 5 years ago.
Yeah.
Did they do it chemically or did they do it with like electric?
The cardio version? They did the
pads.
yeah, which I really didn't want, but they're always in a hurry to, like, I'm like, I did bags, like, just give me some IVs, just keep doing that. They wouldn't do it. And, but anyway, that's kind of the rabbit hole. And then, but I've had even like this year, full cardio testing. Mayo picked me apart to the team. So rhythm test, all kinds of stuff. But I still get 2 a.m., 3 a.m., wake up, heart's beating out of my chest. I started to do some yoga. In certain basic yoga poses, like heart opening ones, I don't know the name of them, was shooting my heart rate up. And then I just fought myself through that. And then it started to get better. But now we were talking about the hiatal stuff, and I've had, is it Riddler? What do you call it? Riddler's point has always been super tender on me. And then that's kind of how we kind of went down this pathway. So sometimes I think I'm getting palpitations off of something here. And I was probably about 100 pounds heavier. About a year. Oh, easily. Yeah.
How long ago?
Like 2 years ago.
Wow.
100 and a half, 2 years ago.
Wow.
Yeah. So I think that's it.
That's a lot.
Yeah. And I actually had a wife that killed herself and a kid. Or my kid's fine. But I wore that through this whole stress time too. So I'm sure there's things attached to me.
How long ago was that?
She was about 6 years ago. 7, 6, 7.
Oh, okay.
Remarried, just a little trauma stuff there, but it's all good.
Next question.
I did, I'll ask it anyway. So I was just gonna ask, have you ever done any
What is it?
NET?
An ET? I have that.
And then I wanted to ask you, Dr. Dombey, could neurological switch have any effect on?
Certainly.
Those are my questions.
I mean, I honestly have no idea what. We'll just start in looking at 5 factors to see. And we hopefully, I know, are you taking any nutrition right now?
I take magnesium.
That's it.
The glycine,
Do you take any?
which slowed palpitations when I get them. Because I travel like 40 times at least a year. So I'd be sitting there and all of a sudden, well, am I going to croak on the plane? Or is it just because I'm compressed and am I, stuff like that?
Probably every week, basically.
Yeah.
But you go take any vitamins.
I've gone through things. And I haven't had any source of bread, rice, gluten, anything for about, I took berberine for 6 weeks and it completely kind of made me feel like I could eat normal. And then I just backed off all that stuff and that's kind of my history for fun.
Let me have you, let's just start at the beginning. And I want to see things where the obvious with regard to. And nothing really.
Well, what, it depends on what hand he writes with. Because if his dominant hand is, the dominant's supposed to be. His head is.
So,
I don't know how to explain.
you know, I think what you're saying is kind of like this.
It's kind of, yeah, it's kind of just ever so
Pretty, okay, let's have you lay it back. You gotta look, I mean, it's kind of. Fine. I know.
I like to.
So you're thinking cat one,
We can check for cat one. I'm thinking, first thing I want to do is check for, actually, you know what, let me have you stand back up again. Because this, I can tie in something that I want to throw out there. I'm gonna have you just stand right here. Now, this is going back to, monitor.
Oh, that's just the CG.
So we're gonna go back to session 1, I think, gait. Remember gait, testing, gait inhibition? So let's do that on him, and then we're gonna test him for backward gait too, and then we'll get into the memory stuff. So bring your shoulder up. Head over. Hold. So upper trap, turn to the left. Good, okay, and then, there. That's good and strong. Let me have you step forward with your right. And just stop and bend the knee a little bit. Bring your shoulder up. So I'm going to ask you to just touch right here. This way. So I'm testing him for what? Touch right here. Category 2, and that didn't seem to show. And that doesn't show. Now take this hand away and bring this hand back. Nothing. Okay, so come back for me. Lay on your mat for me. So, when's the last time that you were adjusted? Probably not too long ago.
Well, minus what you did yesterday.
Yeah.
Cervical.
Yeah. Well,
Let's just call it 6 months.
Okay. Sometimes we're the worst at getting.
Actually, think about it.
his hands are on his body.
So both psoas. Push out for me. And push out. Bring this up here. So you guys can tell me what I'm testing as I go through this. Practice.
You just did sartorius.
Actually, I did. This is
Piriformis. Okay.
piriformis. Yeah. But let's do sartorius. Hold there. And drop it down. See, he's a pretty strong guy. Hold there. That's not, come down a little bit. Hold there. Yeah, that's not too bad. All right, let's check the gracilis. Hold that right there. Pull in. And, okay, so check this out. You see the tightness there. So turn your head to the right. Turn your head to the left. A little bit. Okay. So I want you to take that in. Hold the breath. So we definitely have some cranial stuff going on. When he takes a deep breath in, his toe turning actually normalizes. A little tight on the right. Breathe out through the nose. All the way out. Half breath in. Full breath in. Relax your jaw. Okay. Jaw relax. He's a tough one. Yeah. So I'm going to jump the tracks here a little bit, but I'm going to go straight and do a spinal base one. Because I know that's going to unlock the skull enough so we can get some clear. So
I did have, those, not implants, but, no, where they file all your teeth away.
Veneer.
Thank you, yeah.
oh, okay.
So should you
And
check
I just ripped out all the molars that were, and I'm still missing like 4 of them.
Would it be better to check neurological too then before?
There.
Well, I want to do the cranium first, and then that would, TMJ would be a good next step.
Why?
Yeah, why?
Because it's the keystone of the skull.
Oh, okay.
And because I know I'm going to get the biggest bang for my buck with that cranium.
Even
It didn't until he relaxed his jaw. Down, he was holding his jaw, which was negating all of the tests. So I know once we do the cenobaser, then we can go back and check the TMJ neurological tooth. So actually, gloves, please. Now I'm going to just do. So I'm going to challenge his mastoid on the right and challenge his mastoid on the left. Either one of those challenge. Then we're going to do a spinal basilar challenge. I'll probably do both sides, but I'm going to go test and see. So let me have this arm. This basically what I would do is the correction. So breathe in. So I'm going to do it on inspiration. They usually almost always are. So the first 2 or 3 breaths, feeling the mastoid and feeling the heart. Paying attention to the rhythm. Breath. Very good. I was 11. Now, let's retest. I'll re-challenge it just to see. Now I want to go into jaw. See what we. Now I want you to open. Doesn't really show. I want you to breathe in through the nose, out through the nose, all the way out. So, completely relax your jaw. There it is. So, I'm going to go in and feel. I'm going to go in. Now, if you're missing a molar or two, that's okay. Then it comes on the lower molar. Gently bite. Let your jaw relax. Let it go. Just let it go. Feeling for glide. Let it relax. Actually, the joints don't feel too bad. They feel pretty symmetrical. Feel pretty good. The actual condyles there. Yeah. Bite down.
Talk about the.
Now, 2 fingers from each hand, and we put it right on the. So that was without TL. If you'd have found something, it would have been a vaginal flush. And it may still be there, but we're going to move on to the next one. This is with TL. So if we get a positive finding here, that means we have a spindle issue in the closing muscles. Nothing in the clear, but now bite it. Yeah. What's that? Hips and flat. Don't push too hard. Bite down. Take. So I think it's on the left. Actually, your jaw is pretty symmetrical. The left external pterygoid, that's what it is the back. And when he opens, and it's as nice as it's moving, it does gravitate to the right. Now, testing him on his back could be different seated or standing. So before I go in on that external curve, let's test you seated. And of course, what changes when he's seated? He's loading his pelvis, his spine, in a completely different orientation of gravity. Actually, this way, I might be able to use that. There you go. Now, oh, we can't do that. We need your TL. Scoot back a little bit. I'm going to use it. Now, touch the TL. Yes, right on the joint. First, relax the joint. Now, bite down. Big. Take your hands away. showing it all, okay. All right, so stand for, hey, this is a little more difficult. What indicator muscle will I use?
Slap.
Hmm?
Slap or chat.
Well, I need his hands for TL.
Oh, okay.
But, let's, I could use, I could use, turn this way. I'm gonna use, neck flexor. Now, I want you to TL for MJ. Without doing anything with your jaw. Good. Now bite down. Bring your head back. Yeah, a little something there. Let's go with what we found in Sapon. Good idea. Good idea. I've got a whole bunch of, during COVID, the dentist, or the, not a dentist, the podiatrist next door, we used to have a dentist, in our building, they were so nice, because there for a while it was hard to get rubber gloves. So they had a special place they were getting, and they could get all the ones at once. So they would get us rubber gloves. And they'd say, we're getting more gloves, do you guys need them? So I ended up, I got enough rubber gloves, and then COVID ended, so I got enough rubber gloves now to last me for. So, good. One more time, gently bite down. See if we can get the jaw. Feels foreign for a lot of us to have our jaw loose. So what I'm going to do is I'm going to do these from target weight one left, your jaw to the left. Then I'm going to kind of hold his jaw to the left. In a way, it's kind of like a strain counter strain. So you just pressing up behind the molars on the lower portion of the. If you had a rope, like close to the middle of this, think about it. Okay. Now, my goal is to open. Okay, good. Open. Close again. Watch his change some things. My goal, starting to say, relax. There we go. Your jaw to the right, jaw to the left. Let it be relaxed. It's just completely relaxed. That's some. It's still kind of tight. I could get a little more translation. Sit up. I know, we started out with the stomach. This exercise would be good for you. Close your thumbs. And relax the jaw and then push as you close. And it'll make your jaw go. And there you go. Do it in the mirror, you'll see your jaw kind of
trying to make an underbite.
Yeah, like a slap jaw and a. And yeah. Because you're just really tight. We're laying that. So, we'll recheck, we'll double check TMJ, but I think that's all we're gonna do on TMJ right now. Now, let's go back here, because remember what was happening here. Hold there. These were weak unless he took a breath in. Go ahead and breathe in and out. And they're fine now. That's really good. Breathe out. Now, I want to see. Psoas muscles are good. We want to go to this Chapman area and see if that weakens. Now go ahead and breathe in and breathe out. So he weakens. Now without TLing that area, breathe in and breathe out. Yep. This brings up, we still have to go back in, like diaphragm, probably ribs. But we still have to check his stomach. So. Here. It is. It is. Yeah. Good call. And it could be just our. You know, we're not built 100% symmetric.
Diaphragm touches on.
Yeah.
Yeah. So usually creates that kind of pattern.
Yeah.
Liver's over here, heart's over here, so you have that.
Big heavy, yeah, you got big dense liver, you got small, yeah. Some point, right now I'm anxious to get stomach, but no, we need to treat. We really should treat this neurolymphatic to make sure that's not. So we don't have a percussor here, do we? Activator. Have an activator? Yeah. That one would be. You guys are almost bugged. I keep thinking about it, but it's like I always try to travel so light. They're kind of heavy in both. The percussor I really miss because I use it a lot. Probably, but yeah, but that would be nothing else. This is the T. Now we'll go back to take that away for a second. So as here, breathe out. So not an issue. Now touch the xiphoid. Breathe in. Yeah. Yes. Just tells me that clear. Okay. Now let's check his stomach. Really wanting to check his ribs. I think he's moving around. I want you to touch rivers, Claire. That showed before, and we'll go to Chapman. Then we'll go, I'll just go ahead and challenge stomach up. So now I sometimes will go over and challenge different areas just to make sure there's something else, but this right where the stomach is, that's a positive change. So now I don't have x-rays or anything showing that you know, he's got a true hernia. He never had it. So I'm going to just assume that it needs to be sort of manipulated and stretched and sort of opened up. Breathe in again. So something else we found earlier. He's got subscapularis weakness on that side, and this side was. You have it on this. So he's got bilateral subscapular. Strong guy. What's that? Heart rate. So this is the the scale for the diaphragm. It's also the arm point for the heart rate. So we'll go back to that point and see that.
Certain times.
Right.
Affected on using.
Yeah, that was one of the things. So same thing on this side. We'll see if that. This is kind of tedious, but it makes sure that I'm not missing. Subscap turns right on with that. Now, will it turn on? Is it related to the Rittler point? Muscles weak in the clear, and that tends to strengthen. How about the Chapman? This just helps. Not so much. Not so much the Chapman. The Rittler, it does. So, wanted to do that first because we've seen that earlier. I want to see when we practice how they could maybe practice those subscapes because they shouldn't be weak in the clear. I don't know. This could be from we want to check as a dog. Some abnormal. We do that. Right before we do the track. Sit on the end. He's donating his body to science, whatever you call it. It's part of science. So let's just do we'll do kind of a quick scan on his rectus abdominis. Several of you guys I asked to test this, and I was really pleased. You all seem to kind of get it yesterday, the ones that I asked. Hold there. Right rectus. Left rectus. But obliques, not too bad. Good. Okay. Now breathe in and breathe out. On the out breath, filter. This way. Breathe in and breathe out. On the out breath, not too bad. That's not too bad. So, yeah. Now we could get real fancy and we could do arch a little bit. That puts the rectus a little more. Are you? Touchy. Oh, that's okay. Arch your back a little bit. There you go. Yeah. See if you can cheat. Try it again. Yeah, you were cheating. That's pretty good. You're a good cheater. So maybe scoot out a little bit. That's pretty good. Yeah, arch your back. Yeah, there we go. Yeah. So, yeah. Cheaters never prosper. All right. So, yeah. So those could be better. Let's do the stomach.
Why are you checking the abdominals?
Because
Ric Flair.
Ric Flair. So I thought, why not check? We have as many things to measure as we can. Do the one correction and see how much of that stuff got, fixed. So now we'll do the stomach. So remember, what did we? So we had some weak abdominals where we really challenged people with a little bit of extension. We had positive Rittler, Chapman, and challenge. We had we did TMJ. That should be out of the picture at least. We also had a positive pulse point. So, and we had weak subscapes. So that's the collection of findings we have. So, but what we're going to treat is the stomach. So, after much delay. So, breathe in deep. trying to feel where that stomach. As his breathing deepens, that gives it a chance. For that gurgle, but I felt a little bit of a first thing. I felt a little bit of a. It's nice when you get that real satisfying kind of thing.
Yeah, so what is your objective when you're adjusting, and how do you know like which direction you're going?
Well, I challenged it up.
Mm-hmm.
Didn't like it. Body didn't like it. So so I'm going to pull it down. It's actually, yeah, it's a direct challenge, direct correction.
And you're feeling for.
I'm feeling for. I know his stomach's there, so I'm feeling as much as I can. The stomach's there. It's kind of under the ribs, and I'm trying to get my fingers here so I can get on the edge of it. And then as he breathes out, I'm just trying to get as much of it as I can to hold down while his diaphragm lifts. That's really my objective.
Okay.
It's not the most precise thing in adjusting, but it's a lot of visceral work is not. It's as much intuitive as it is, otherwise. So, but that's definitely you know where the stomach is and you know where you want it to be. You know you don't want it sucked up. Now, if he didn't challenge, I wouldn't do it. I wouldn't do it. So when we get 3 or 4. So I'm going to do the challenge again, and that usually clears pretty quick. Rittler doesn't show, and Chapman doesn't show. Now, what else do I want to test? Subscaps. And we also want to test subscaps.
Psoas.
We want to test psoas and its relationship to these points. Now that feels better to me. Bring your legs down. I think you might have been flat last time. So that's pretty good. That's pretty good. And that's really good. So those are not weak. Now, the pulse point is in the PMC, and I'm doing Dr. TL on the pulse points because you can't. And that doesn't show at all. I'm going to go up to the middle one, see if there's something I'm missing. To the proximal one, nothing. So right now, his body's not really, it's fairly happy. Let's see how the psoas muscles are doing. Okay. Good. Touch, once again, Rittler. Good. Chapman. And have you challenged him? So right now, those aren't showing at all. What else do we have?
The left one was weaker. Do you want to start with the left psoas?
The left psoas was weaker. You're right, it was. Yeah. Strong now. Breathe out. Good. Touch once again the diaphragm, Chapman. I know which we. Breathe out. So it seems to be fine. Now, we didn't check, since we have him in this position, and since I often see these together, we didn't check his ICP. Now, I can use a remote muscle and have him do an enhanced TL. And it's like we got. Now, so we need to treat that before we let him escape. Where's that name? C. Magnet will pick. That's good. I'm just going to stick that right there. still kind of figuring out ways to use that. That will kind of hold the TL, so it frees me up. So his ICV needs to go. It needs to be closed. So tell me why. I need to close this. So I go close that. He's got that. So open ICV, more common than closed. Open ICV, C5L1, love it. Open ICV, right bicipital groove tender. That's one of the Chapman reflexes. Okay. Remember that?
So are you gonna, and then you're gonna.
I'll check those after I. Actually, but I'm just kind of going through the. So, closed ICV, 11 C3L3. Closed ICV challenges down and out to open. That'll be closed ICV. Often will result in like a pseudo sciatica. Either one can actually, open and closed. Open ICV, a lot of times the problems are all on the right side. With closed ICV, sometimes you can have bilateral weakness. So either open or closed, not good. So we could check him because it's open. We can check him for C5. That's what we asked. It's challenging. It's a tough kind of challenge. Let's go to L1. Challenge that does show some willingness. So that's really, yeah, that's right in there. Let's do the ICB, and then we'll have you flip over, and we'll check L1, and we'll check C5 again too. Bring your knees up. So knees up for both stomach correction and the ICB. Slackens the belly. I think people feel more secure when their knees are up. And when I do the correction, I try to get down. I want to be kind of underneath the ICB. No, please come close if you want to see what I'm doing. You guys do. Oh yeah. Yeah. So the guide you have it's right line at Bernie's point. But see, you take the line between the SIS and the milli. And they say it's halfway. It's really about 2/3 of the way. When I go after to close it, I get down low, just above this crest, and I kind of get underneath. Good, breathe in. As he breathes in, he kind of provides some pressure from above. Breathes out. He can. I'll hold it while he breathes in, and that creates a sort of a pumping effect on all of his organs, but more time. I think his diaphragm can do some of the work. Now we didn't check bicipital. Through, if you know, these are usually in a real hot one, they'll be that not too bad. Okay, now let's have you hold that and enhance TL. This hand. Oh, like. Now lay face down. We're gonna check them for what? L1, let me get you.
It was open.
Every one of these things is a little different, these tables. Okay, so two options here. Find a strong indicator. Bring this guy up here. Humans?
Uh,
Oh, wow. Let that relax. There you go. So I'm gonna go with the hamstring. Now, it's hard to TL this area. Can you reach right there? Not,
probably not this one.
try it. What's that? Good, yeah. You can magnet it. Sometimes if they can't reach it, you can doctor TL. There it is. Okay. Let that relax. The thing is, one question I always have is, if I ask the patient to work their shoulder, now I'm TLing their shoulder. I mean, I'm challenging their shoulder too. So it complicates the test. So, yeah, so this, there it is. So that's where he's, let that relax. Try this side here. Yeah, so right here is where I'm finding. So this feels like L1 is stuck in the left rotation. Like it's kind of stuck this way. Got more spring this way. So if I was going to adjust it, I would be adjusting this. Now I'm going to go back up to C. Can you touch C5?
I thought for
Open is C501. No, wait a minute. Are you right? Am I switched? Hey, oh, it's good to see you. You're absolutely right. No, I'm switched. Okay, so forget everything I said. Everything I said is a lie. Okay, so TLC3. That's crazy. Yeah, you're absolutely right.
that's weird, so it's okay.
Okay, so C3. Now, take that away. This does TL, but it's hazy. Let's go to C3. You doing okay there?
Yep.
Charles? Yeah, just hazy. So let's check the mid-cervicals. Is that L1, L2, L3 area? It's like, it's murky, it's not giving you really good information. So I'm going to go right into C. That is crazy. It's just not showing.
You corrected it by CV though, so maybe.
Hey, and we should have checked it first, right? Okay. So let me have you sit up and fix that. Check the L1. Jury's still out on me. Sometimes I wonder if maybe. She's not sure. We're gonna let sleeping dogs lie, as they say. So we did ICV, we did stomach, we did TMJ. That would be all I would do in a first or second or third best. I would, but we got some really good things we monitor now. Subscapes, make sure those are right on. Now take your right hand. Emotions aren't wanting to show up right now, but there's always a chance there's emotions and shy. So at half these points, it's there. Right up. Stay with that for, yeah, I'm just going to give you, keep your eyes. But you came up with too shy. Liver. Came up liver, right? Stomach? Doesn't matter. I mean, it doesn't matter. Came up with something. Yes. I'm just touching it, just kind of basically doing like Chapman. Mainly, I'm just trying to keep what the energy that comes up with the emotion. I want it to turn around and skedaddle, or at least kind of get shaken back into that boxes.
With sticks, open up any of the.
So something going on with all of us, but with liver and emotional things. So I don't do any tea like any tea in my office anymore because I don't want to know about the stuff.
Don't like the emotions?
Well,
Make you sad?
I see the, yeah, well, you know, I see the value of, yes, I've sent it to other people, but you never know what you're going to get into.
Yeah.
And I find their stories so interesting that sometimes
You're just asking questions sad.
it's like, I would rather they bring it up and then I try to find where it's at in their body and just try to help their body dissipate it. And, you know, if they want to share something, like Charles already shared, he had a lot of emotional and physical trauma. So think of the second most stressful. That doesn't strike me as the stomach. I mean, the liver. Stomach. It's more kidney, maybe. So that would be, you know, here, put your hand over here, or I'll put my hand over here. You go ahead and close your eyes. So kidney typically is fear.
Bladder's fear too, right?
Bladder's fear. You know, I've heard it said many times that there's really only two emotions. There's fear and love. And we're in, and you know, fear manifests in all the other emotions that we find. negative, and love is all of the emotions that make us feel better. So ultimately, fear is usually behind all of our negative, certainly behind our anger, our grief. Okay. It's not. That's and that's like wall for that. Okay, that's good. That's it for now. I mean, we kind of went through two things. Maybe he's only got two things that stress him. Probably not. But I mean, the most stressful things sometimes aren't the ones that are they're the ones that the patient doesn't realize they're stressed. They don't.
What was the first one?
First one was liver. Second one
So anger.
anger.
Or-
Usually
And
anger
then
is
the second one was fear. Both of them.
Yeah. It makes sense, yeah. So I know I've talked about this before in this class. Are you guys familiar? Any of you familiar with the book Power versus Force? Some of you are.
I think you've mentioned.
I'm reading that right now. It's a.
Are you? Okay. Yeah, yeah.
You get to read all the books.
Yeah, good for you. Yeah, so I love the concept in there and the hierarchy of consciousness. Are you familiar with Hawkins' work, the Power versus Force?
It's been a long time.
Yeah, I have a sheet and I use them in my office, and I'll test people and see where they're at. But you remember 200 is the break-even point. At 200, you're actually giving as much back as you're taking. Is one way that he talks about it. But I've read probably 4 of his books. They're all amazing. He's been gone now about 10, 12 years. I think. He's really old. But, so TMJ, we did sphenobaselar, TMJ, we did the ICV, the stomach. We addressed, or at least brought into the algorithm, the subscapularis, and that seemed to clear with the stomach adjustment. Did 2 emotional releases. Yeah, that's probably. Cool. Yeah, drink some water. Great stuff. Yeah, my pleasure. Yeah. So what's your situation?
11:15. Can we take a break?
It's what?
11:15.
Let's take a short break.
Yeah.
Yeah. So hopefully that was helpful. We kind of went off script.
Chuck. The reality is things.
So you're talking about
They're there. All over. Even if the correction is something.
I always think of this.
So that's why you got all these things away, because if you start doing a lot of remote stuff, I mean, they are kids.
So you're seeing this. You saw that in the
So you usually lead with more. Exactly.
Yeah, I think
The
my
joint
boss.
and the subject.
I know that was. Is,
And what's that?
instead of
There are emotional triggers. There are also triggers.
and a lot of times
Hockey's even worse because the emotion, the concept trauma, they can't downregulate.
to build more.
So even after
It's also part of the
some box breathing with some of the guys that are in the mood,
flexible.
you know, it
That's like works effect flex your foot away from. There is, we don't have it in. There is some muscle tests that address that. And that are kind of like if you do a glute
No, I
max,
haven't. I've worked on, so.
glute max, and then they're kind of different. I can show you how to do it. Basically, bring the knee off the table, externally rotate, medial like that, and I figure it's like the coccygeus, sacral coccygeus. This iliococcygeus and coccygeus. So it's coccygeus, those are really good if you're doing test those, and then go in and do work.
In that environments, yes.
I'd love to. I don't do them. There's a couple of ETs in my area. They don't do it.
Oh my God, you have to do it sometimes. It's up to 15,000 of them, they'll do them wrong, and then they create another problem. So, but it's, so sometimes I get 3 minutes, sometimes I get. So privately, I'll take as much time as I need to.
Yeah, the motions. Yeah, you never know. But sometimes motions are just kind of affecting a little bit, certain areas. Then there's times where what seems like a weird motion is huge, and
Never figure out how to determine specific characteristics of each one. So then
yes, I have the body people. Yeah, and I actually I didn't get through all of it, but I'm trying reading.
You got to do a lot of them
Probably
because
based
it's
on
used
the original.
based on how much pressure you're putting on it. So you got to
And then that's kind of what that kind of takes on.
So
And
yeah,
that's yeah. There's another Dr. John Diamond. Don, he was a good friend. He wrote a book. Yeah, it was called Your Body. You may have. It was a huge success. But he was at our ICA conferences every year. He was an interesting guy. He was really from New Zealand. But he lived in New York. He was a psychiatrist. And became one of the AK debates early on. He's gone now. He's yeah.
Dr. TL, all around their system when they're in a specific position, and then determine what now puts them back to full strength. And then try that one. In that area, it could be up into the shoulder, then go back into the muscle test, all the way into there, and then go back to clear that out, and then go back and see if that.
Is it like the anatomy training?
So Myers is but the breathing stuff like that.
Myers talks about that. He talks about like there's some plays, you know, and like there's like a spiral line.
Because
Even
yeah,
like the exercise
center of
is
gravity in
do
the right side, we're
like
standing.
cross-body, like upper cross.
So we're dealing with frontal plane issues. They can't get that. So, so there's a whole, fascia work, all kinds of things that may actually have them reposition themselves.
About that.
And it could be because we're in the environment.
It's the book that
Doing those specifically.
Mark Ellis.
What's going on? How do I stay back here? I'm trying to do that, and I can't stay down. Big picture, we can every single word we talk.
We can IVF, not like the semen. IVF was a semen. Oh, frame.
I know, I was like,
Intervertebral frame.
oh, yes, yes, yes.
No, I
I hate
I
that.
just gave one thing. So I have a consistent platform because it's also part of the testing. Right, so.
Now it's SOL.
So I'll go based on. Because you're always trying to find
Superior orbital, nope.
So lots of different.
SOL, I'll use SOL.
probably shut up too.
It has to be, so I know.
So you see, so it's that structured function, fascial plane, positional symmetry, their inability to transfer from left to right, types of things is kind of where we're going. A lot of guys can't take that medication.
Oh. No,
Makes
that's
sense.
that's
Okay,
all.
yeah, it makes sense. Violation. Okay.
Okay.
I said it's fine.
She doesn't they get a cramp in the muscle. That's one of the biggest ways for me. Instead of me just feeling the muscle, and they're using the compensation pattern. To me, that's a good. So if I'm doing a lot of this all the time, so I do two lots. Yeah, that's all right. Hold that back. And then if something doesn't make sense, we're testing the whole arm. Then I'm like, I found this the other day, and then something's not making sense. Your elbow's fixing, and I'm testing an arm that's already set them up for failure. So it could be knee, it could be something like that. So if I don't see the remark,
You're what?
Closer
To being done.
It's probably some.
Well, I'm on slide 22 of maybe.
So it's like, all right, let's just go see where it is.
And there's some that I was like, oh, we never really know. And we think, well, what did he do? What did he do? He put them in like extra lines.
Oh, are these? Is
But
this like
that
a?
builds the foundation for me.
Do they? What is this? What is this?
Look,
Super flex.
Then it pushes him to.
we start implementing other things.
Is it like a physical influx thing they set up for you guys?
Once you start
Oh,
opening
Because
those
there were
up,
certain ones that were
priority,
That's the cost.
Yeah.
that's all. Set up.
First, it's not.
I never
Some of those are
This one was on my philosophy.
Like, I know it's just weird, I do it all the time, I'm just gonna mix it up.
I get something.
But then
The way you were describing it, I thought you were talking about. Oh, shoulder.
there's
So many people.
I wanna make sure it's
I know.
Said,
And then you go, what's the point?
Okay.
why
Just
do
like
you do it for something?
Let's put anything.
4, 5, 6, 7.
Why would they make you do that? Oh, it's like I get it, but like.
I don't know, so like,
For the sake of the structure and function,
Honestly, sometimes it's like.
we have different divisions of the app that we test.
Yeah.
The lower.
but this one was for the shoulder. They didn't give me anything. They have a motion for
Those
certain
right there,
ones,
you
and
can
then
train,
shoulder
turn right back on with a second.
And it, like, you don't need to like say, like, okay, this is nervous, positive, like, things would indicate this and this, it's just for, because there's this, and you give like
It still doesn't come back.
I was like,
So what, but what if you gave like something else that was
That's come back,
completely
you
different?
start seeing repetitive, you kept obvious.
Did it have, because I know they have like a certain list of things that they're like, okay, we're basically expecting them to say this. But what if we said something, okay, so say if you were like, oh, I'm gonna do, sorry,
Deeper the computer.
do they have a neck thing? Like, was the issue in their neck?
Underlying that.
so all I got was on, that was on page.
Their experience
No other.
was,
True, but if I wanted to.
they would go.
But I'm saying, like, what if you would have said that though?
So I was, they didn't use early to do that.
Yeah.
Not even confirm it.
That's so weird. I don't know why I'm not, it doesn't make sense to me.
And it's not, we're losing,
Yeah, so
losing,
we're just to know how to use that information,
we're losing
like,
that.
I would expect to be positive.
It's hard to know where it's at.
Yeah, that would be the only thing.
I still come back to the,
That would be the only thing that I could.
right here and try to.
Can you
The actual.
and show it?
It's like, I know it's.
So
Why
it's
is it
just,
that?
So it's literally just like testing for cancer would.
It sounds like
Yeah.
like, so.
Yeah.
Well, I think.
Is that what it
That's why
said?
That was, yeah.
Unless you're
All
jamming
day,
it.
you can just have a four shot.
I don't know if it's depression or deep.
Okay, so you're saying that it said that on your paper.
So, so the findings were,
It was literally in there.
Internal.
the cervical range of motion was, for rotation, was 75 to 70 degrees.
But no, but that's exactly, so something.
So many of the things.
So,
You're gonna find it.
So, but that's where like they had a
This
next
cycle pattern that you know, trauma and history, terror.
I'm just trying to think about how this makes sense, that's all.
I know, but they didn't have any, they had no, it was all meant to be radiation.
What is the
Opening it up, and then you retest them.
I thought it's here.
Or when you just come here for a second.
What do you want?
Oh,
Nonsense of course.
I'm just gonna watch this because I wanna see what, oh.
These are, oh, no, I'm good, I'm good, I will confirm it. And then they, when they're ready, they just confirm the work. They found a way that they can, right? So it's, exactly, so it's just a constant being of check points, check them out.
Yeah.
So they like.
And they check these, okay, now.
Oh yeah, I just can't go. So.
Left hand under.
Oh no, it's there. You gotta bend.
Now I can go back and test it. See what it is. So you look at one, and then I dive into what I want to do.
All right. That's so down here. And I accidentally clicked on your email.
Let me
The whole
in.
thing keeps bouncing.
100%.
This test is done. This test is so done. So did you see it?
It's so done.
So I literally.
I mean, that's not correct. That's the only mechanism, but that's dumb. It's a dumb excuse. It was shoulder depression test.
So the latter one.
Yeah.
And then they did appendicitis, or equivalent motion, inflections, and even degree.
That's why I said this. And then I just watched the video, and that's literally what I just did. That was
Yeah, and then but I guess it. That's what.
That's what I was thinking, like a circle pole, sort of thing. Agitated.
In their case, having
I really
so I was like, I thought that was cervical. I guess that's what they said.
You haven't done blood treat?
What's that?
But okay, yes, but also. She's so like freaking CrossFit.
Yep.
See, my most thing, I know that. I didn't know how to use my. I was like, well, I'm obviously going to look for all these things and find things that support it. I didn't know I could say, oh, we would expect certain calls to know things like how she likes this, and then especially how these things. Because like, I can still say, I not as people expected, but we would expect her to not have this.
Basically, be like the same.
But I don't know of my two things. Not what made me feel. That's good to know. It wasn't that I didn't know the diagnosis. The verbiage.
That's, I see how that's like stressful.
And I think too was more than
So muscles are in step back. Step forward, left.
all that, but I know it's just.
Simulate.
I was like, no.
Jaw line.
And you can't get it though. And you can't say something else. Like clarify this muscle.
Jaw. So that's here. Was your jaw
Whatever that one is. Tears to the muscle. So. Yeah. Who knows what I said? The strain. Yeah, I'm done with strain. Strain is.
Yeah, we have time.
I studied for it.
Yeah, well, I've already started studying.
I've tried to start studying.
I got
I would definitely
but I'm
focus on
like,
yourself.
I did for one week. It's really
And then do this exercise. several times a day when you kind of.
I don't think I know the
It'll tell you how it comes back. That will be trained to reset how the brain is expecting the child to be. Yeah, that could impact you. There's a child blocks of training. Training is blocking this. Yeah. Somebody, we're ready to go. Another half hour before lunch or so, right? Yeah. Okay. I want to talk about two things here that we need to go over. One is spondylogenic reflex. So we talked about hologramic subluxation. Some of you, I don't think you're here yet, but hologramic subluxation, or otherwise known as bent bone, and you have an intraosseous derangement in the bone from chronic, like abnormal pressures or tension on the bone because of the piezoelectric effect. So it's something you find a lot of times in chronic stressed areas. A lot of times the small bones, you'll see it a lot in the ulna radius, fibula, metacarpals, metatarsals, fingers. You can see it in the zygomatic arch. I've seen it there. Anyway, so hologramic. It's basically it's a two-headed TL from one end to the other end of the bone, and then if it positive TL, then you challenge the bone one way, then the other way, then you get a rebound challenge. Breath in, breath out. Correct on the direction of challenge, phase of respiration, and the gate of challenge. Hologramic. Now, spondylogenic. This is one of those things that it's in the synopsis. If there may be some tests on it, it kind of overlaps with a lot of other techniques and different models. So these are based on Dvorak and Dvorak's studies. These are the pain areas that show up when a given vertebra is, a given facet is injected in the sacrum. So it talks about here what they did. So they developed this technique out of this work. When you have like a chronic, maybe a chronic subluxation, maybe a chronic visceral issue like hiatal hernia or esophageal jamming, like ICD, any of those kind of things. Maybe gallbladder, maybe where the gallbladder was. A lot of times there's need for visceral work there. This technique seems to be very helpful. What you do is you look for these pain patterns, and then go to this chart here, and this has reflex points that relate to all the different spinal levels. Use this to TL. You can palpate it, LTL too. And then let's say, for example, you person has pain kind of in their back, right, near T7, for example. And then you come over here and you go up here to right about here at the top of the shoulder of the spine of the scapula. T7 therapy localizes and it's tender. So then you would go to T7, challenge, TL it, challenge it, see if it's subluxated, and then go to the love it. So let's see, what is it? Love it to T7 would be T6, T5, 6, T4, and T4? T4. T4 is the love it to T7. So then you go to T4 and you would challenge. Now, what they found is after you do the adjustment, for about a minute, you tap on the love it at about the same rate that your breathing is, and that's supposed to take this visceral pain. I don't use this technique. But this is one of the classic techniques. We can try it. Does anybody have any visceral area pain?
Yeah.
Where?
All
All over.
but mostly right now in the upper.
Try it. We can check. We check. Have a seat here, please. So you sit and face that way. We'll get a strong indicator. And where is the pain? Okay. So that would be, according to this, that would be, let's say, probably T10-ish. So you're talking about right here. Up on the above the so it'd be right. So yeah, T9, T10. So then we go to the other chart.